Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos. I am the founder and creator of Finally Friday and Appeal Academy and Top Gun Audit School. And we are live on the January 15th, 2016 Finally Friday show. And I want to thank you for choosing to spend your time with us here on Finally Friday. We've got a lot of great stuff to discuss today. A couple of things in particular. We'll get to those in a minute. I want to tell you first that Finally Friday is sponsored by the Health Law Partners, bringing solid advice and real solutions to healthcare business nationwide. We're also sponsored by, and my co-host runs, Recovery Analytics, a company that's committed to your success. Finally Friday is also now sponsored by, we have two new sponsors, MedLink's Cost Containment, makers of the Healthcare Audit Tracker, and you can visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. Our other new sponsor is Aerolib Healthcare Solutions, a patient-centered total quality management consulting firm run by Dr. Deepak Bahuja, and you can see there's an offer for, they are the creators of the Physician Advisor's Guide DVD, and you can now get that for online. The DVD is normally $4.95. You can get it now for $100 online, so you can look that up. Anyway, today we're going to go over some highlights from recent news, and we'll probably focus the discussion on the puzzling behavior of the QIOs and some concerns over the new but not so new Medicare Advantage Recovery Audit Contractor. Now, that's a real puzzle. Okay, maybe not, because the program really puts CMS in a bad light, like they need more of that than usual. Anyway, or like they need anybody's help doing that. Yes, and Happy New Year to all. I don't know why I completely forgot about even saying that. Okay, so I have my loyal and faithful co-host on hand, Sharon Easterling, who's an auditor, speaker, and appeal writer at her company, Recovery Analytics. Unfortunately, Bill Malm, who's a practicing clinician, a speaker, and a certified medical auditor, he was called away to a meeting just before the show, so there's another example of the real world getting in my way. So anyway, that's I just want to make it clear that the opinions shared on this show are those of the panelists and not necessarily representative of their employers or, well, I guess Sharon and I are representative of our employers since we are our employers. Anyway, my opinions are my own and no one else's, okay? So now, before we get started, I want to, if you were able to watch the slideshow beforehand, you saw some of the instructions on how to use the room, but I think there's probably a large number of people on today who are kind of new to the show. So let me switch over to the website. I would just want to briefly go through those pages, if I could get it up here. I'm rusty, Sharon. I do not have things set up the normal way. I've been gone too long.
I know. It's been without Finally Friday too long, Ernie.
Yeah. Okay, so here we go. If you any page on the site, you can find this. You just scroll down, and you will see this thing with the green buttons. Click on that. It takes you to this page, and you can find all the instructions on how to use the control room, how to get the audio either by dialing in, or you probably have to download a little app to use the internet audio. And the audio is separate. Of course, if you're hearing me, you know that already. The chat box, highly recommend you open the chat box. Somebody's telling me my number listed is not working. You're getting a fast busy. Try any of the other numbers that are listed. You can find those, see in your, if you choose that green button on the left with the phone on it, it should give you a way to find a list of phone numbers. So there are so somebody's saying the 404 number worked. So you might want to try that, viewer 155. Of course, they can't hear me. Well, maybe they can, but they weren't on the phone. I don't know. Okay. So then there's the Zoom chat box, of course, I already told you about. That's an active chat box in this show. Zoom, if you want to zoom in on something on the screen, you don't have to ask me to. You can do it yourself. But I will warn you, once you zoom in, you have to zoom back out yourself if you want to see the whole screen. There's a participants list which you can open, and you are listed at the top. I think always that works. And if you point at you, you'll get a little dialogue will appear on the side that'll let you change your name. So that way people can talk to you, or I can talk to you directly. That you can do a private chat as well as the chat to all. So when you're doing chat, by the way, be careful that you know whether or not you're selecting all or to somebody in particular. If you click on that all thing down here at the bottom, it gives you a list of all everybody who's showing up. So okay, great attendance today. It says more options. I am not going to give you control of the show. Sorry. I don't know why I have that on that page. I have to go back and change that. Okay. Okay. Somebody found out their company's having phone line issues. Okay. Well, hopefully you can get the audio on the show. All right. Let's get back to the slideshow. And okay. So. Previously, the last Finally Friday show we did was on December 4th, and it was at that time we were talking with a couple of the experts. Well, I'm not supposed to. They can't say they're experts. That's what it is. Lawyers can't say they're experts. I can say they're experts. They are experts. Jessica and Abby are experts at appeals, and we had two of their colleagues from Health Law Partners who were experts at Stark Law, and trust me, you want somebody like them advising you, because that stuff is darn... You think 2 midnight rule is bad. Sheesh. Anyway, so that was in the last show. You can find that on the website, because there were some major changes made, finally, that they were able to talk to us about. This week, these were all the things we were going to cover. There's a few things we really aren't going to... We're going to have to put off until next week or another week because Bill wasn't able to be with us. Somebody says they're not able to dial in, says the ID is invalid. You will get the ID on when you are... If you are on, you got the chat box open. What you want to do is click on that little phone icon in the upper left corner of your screen, of the view screen with the control panel. There's a little phone icon, and it's black panel with it's in orange, I guess. Click on that, and it should give you, well, it will give you the correct ID. That one always works. So just be careful that that's what you're doing. It couldn't be that you're putting in dashes, because that doesn't work. Okay. You can't put dashes in on the phone. Anyway, all right. So hopefully they get that fixed. Yeah, and there's somebody put the ID number in. Okay, great. It's great advantages to have in this chat room. Okay, so we were going to talk about the OPPS final rule because there do seem to be some confusion about observation and billing it and using it now since the new rule, and maybe that's just in general anyway. And there was some talk about that on RAC Relief Google group. By the way, if you are on the show and you are not on the RAC Relief Google group, put your email into the, well, there's two things you could do. You could go visit Dr. Hirsch's website. Dr. Hirsch, can you put your URL into the chat box so everybody can see it? He's got an easy way to link to it and go get subscribed to the RAC Relief Google group. Yeah, there it is. RonaldHirsch.com. Or you can put your email into the chat box, and I will see that I will send your name and your email to Dr. Larry Heglin, who runs that list. I highly recommend you get on it if you are not already. There's over 1,500. There's over 1,500 providers on that list. There are not that many vendors, and there's not much advertising ever happens on there. You see some offers once in a while, but it's incredible, great information source, and you can talk back and forth with other providers on that. And there's emails daily, but you can get a daily journal list of them, so you don't get them keep coming as they come through the day. You can get a list of them, or you can even do that weekly. So it's really highly recommended that you get that. Okay, some people putting their emails in. Yeah, I'll make sure you get. I'll send your names to Dr. Hagelin. By the way, I want to tell everybody the show is. I forgot to mention earlier. The show is recorded, but the chat box is not. Now, I make a copy of it in order to keep these emails or something, but that's all. And I don't normally copy the chat box out to text. So that's not recorded. There's not a discoverable version of it or anything like that if anybody's concerned about that. Okay, so we are going to talk about the fact that the RACs are back, and there's not a whole lot to say right now except that they are definitely showing up more. Sharon, did you say you're seeing more denials showing up, people sending you denials to review and stuff?
Yeah, I have had a couple of people reach out to me saying I have a stack of denials on my desk. I got to send them to you. So it looks like audit activity might be increasing.
Yeah, which we've been seeing anyway in the last since October 1st, but I kind of expect that's going to ramp up here as we go. And then you might want to know how you track their new issues. They are posting new issues to their website. Somebody asking Sharon to speak louder. I don't know if you can get closer or something, Sharon. I can't turn you up on this. Anyway.
Yeah, I turned my volume up on my phone.
Okay, there you go. That sounds better. Okay, so I'm going to go through and show you how I track their new issues now. Now, it's not what I used to use with the RAC Shadow. The RAC Shadow used to be a set of software that actually checked those pages every 15 minutes and looked for any changes on the entire list. I don't have that software anymore. My programmer went away, and I'm looking for a new one. But anyway, I'm going to show you how you can possibly do that with a free tool that I know how to use, and I'm going to show you that. We're also going to talk about the QIOs, and, you know, it's to me, it's funny. It's like, why are you asking for records to review if you're not even following the rules? Can't you read the rules? And the problem is not that they can't read the rules, so it's not that. Anyway, we'll get into that in a minute. And then we're going to talk, and Sharon's going to talk a little bit about these new RADV audits, the risk adjustment audits that are being done on the Medicare Advantage plans by a new RAC. They're kind of new. They're not so new. They've been around for a while, but CMS is moving very slowly with them. So the question is this a good thing, a bad thing, or an ugly thing? And then ABNs, we're not going to be able to talk about that today because Bill was going to talk some about that. And, of course, he's not with us, so we'll do that on a later show. And observation, I'm saying, are we messing around with Jim? The Jim Croce, I'm referring to the Jim Croce song, you know, you don't pull a Superman's cape, you don't spit into the wind, you don't pull the mask off the Lone Ranger, and you don't mess around with Jim. So to me, it's like, the question is, are we fighting City Hall by trying to do so, you know, by trying to keep doing inpatient the way we've been doing it? It's obvious that CMS wants us to use outpatient more often, and probably all the insurers, I guess, all the so-called payers. So that's what we're going to focus on in the next, probably the next 6 or 8 weeks, is talking about why do we, you know, how do we deal with that? How do we get our physicians and how do we get our administration to stop saying, you know, we want inpatient, we want inpatient? You know, the big deal is take care of the patient. And if it works out that you can bill it for inpatient, fine. If it doesn't, fine too. Take care of the patient. The money will come. You will get paid. I do believe that, although I think that the payers are messing around with that. But probably the best thing we can do is to quit fighting the trend. It's like betting against the trend in the stock market. You can't bet against the trend. You're going to lose your shirt. So anyway, that's what we're going to talk about in the near future. If you haven't attended, I know there's a bunch of you out there that haven't attended because I know a lot of you who are registered and you still haven't gone and watched the webinar. There was a free OPPS final rule review done by Bill Malm, another great job by Bill. He's been doing that for 15 years. So we got Vitalware to pay for and sponsor the whole thing so that I could broadcast it out and we could make it free to everybody. And it is now virtually permanently available. It'll come down eventually, but it's very easy for you to get there. It's on the website. It's all over my website, so it shouldn't be hard for you to figure out. You can pick, when you go to register, it will send you to a page that lets you pick a day. It'll show you the next 5 days that it's available, and it'll show you like 3 times each day in your time zone that you can go watch it. So very easy. Yes, Stephanie Daniels commenting, yes, they want more inpatients. They ought to conduct some classes that teach doctors how to document medical necessity. Oh, but don't you know they do that? They tell Congress all the time that that's exactly what they do. Every 6 weeks they teach us how to do that. They get online, and for an hour and a half they read the regulation to us. That's their education. And they think that they do this wonderful clear, and that's what they tell Congress, and apparently Congress believes them. Yeah, on what planet? That's why I always ask them, how many, when you go out in your backyard and look in the sky at night, how many moons do you see? Anyway, so that is still available, and these are links to them. This is in the handouts today in the slides, so you can find all of these. You get the handouts even without attending. There's the AAPC CEU certificate, and there's one for the CCMA, which is the Certified Medical Auditors group. They also approved it for 1.5 hours. So give that to the people who need that kind of stuff. Okay, so the RACs are back. There's a vision of their 4 pages where they list their new issues. They're required by their contract to post new issues on this site before they actually start conducting reviews of those issues. Forget about trying to argue with anybody about whether they actually post them before they do the reviews. I don't think they do, but it would be very difficult to prove, and you try to argue with them, they won't care. So, the funny thing to me is that they still argue that they're saving the trust fund. Well, they've returned to date $5.4 billion. That's less than 1% of what they're going to spend, what government's going to spend on Medicare this year, not counting the past 8 years. So, it's really a ridiculously small number. Let's see. Dr. Field saying the best way to get inpatient only is to stop the outpatient patients in the ED. And that requires malpractice reform. Okay, well, I'll let you guys talk about that. Good comment. Glad to see you're back with us, Dr. Field. Anyway, here's what I promised about if you want a free alternative for an ability to track the RAC new issues pages. You want to go to this site. It's called changedetection.com. It's totally free. I use it to track. It doesn't track the RAC issues very well, but I'll tell you about that in a minute. But it's great for tracking things like Medicare pages, pages on CMS website. Because you can tell it to look for a single character change or a substantial change, or I think it lets you adjust what you consider a substantial change, or if there's just, a certain number of lines change. So it's really good for looking for, it sends you an email when you set it up. It's free, and you don't get a bunch of emails from them or anything like that. You don't get marketing. So you get an email that looks something like this, where it shows you which page changed, and it shows you a link to where you can go see what the change details were. Now, that's not the most logical thing you can find, but you can, if you get used to it, after you see this 1 or 2 times, you'll get used to what it's telling you. Now, the trouble with the RAC pages is the RAC pages require you to actually click things like several clicks in order to get to see the list in a way that you want to see it. And so that's the difficult part. That was what my RAC Shadow software did. It did that, and it went through every page, copied everything down, and it compared it to my database of what had been there before and looked for every change. But this, you're going to have to do it manually, but at least you got a chance. So it will send you, even today, I still get probably once a week from a couple of the sites, I get a notice that something's changed. on those new issue pages. So then you may have to go in and try and figure out what that is, but at least you've been notified there was a change. Sometimes that'll be important. Dr. Hirsch says, yeah, I have 31,000 emails. No, that's just the ones that I don't really read. I get tons of emails. Yeah, so I go through it every day, but there's a bunch of them I don't even bother to read. Okay, so, somebody's asking me how I calculated the $5.4 billion figure. That comes from the Medicare reports. They produce a RAC report every quarter. And if you go back and calculate those, you can figure out that that's a rough figure, but that's pretty accurate. It's over $5 billion they have returned to the fund to date. Not a year. So it's and that's what they claim, Now I don't really know if that even includes. Well, how do they count the ones that are in, the 1 million or however many are left now? What, 700,000 appeals that are waiting to be adjudicated? They're in the Omaha list, waiting for an ALJ to look at them. I'm sure they count those as denials because they've already collected the money. They have. They took the money back on day 41 and they put it into the trust fund, so they've returned it. And that's the way they feel. And those people really do think they're the folks with the white hats. They're saving Medicare, as if what they're doing makes any difference to the Medicare trust fund at all. I suppose, considering the changes that hospitals and providers in general have had to do in order to survive the RACs, I guess it's probably had more effect than that. But come on, give me a break. You're not saving the trust fund. Okay, so let's leave the RACs and let's talk a little bit about the QIOs. Now, the trouble with the QIOs was everybody was hoping, and they have been really responsive, and they do seem reasonable, is what I've been told. And I know Dr. Hirsch, I know you've talked with them a number of times, and there have been several people on RAC Relief that have talked about issues they've had, questions they've had. They do get good. They do respond to you, and there are some contacts available. You can go look on their sites and just go to those contacts that are listed, and they will respond to you. They respond a lot better than the RACs ever did. So you can go do that. But there were lots of questions about, what about using the two? There was confusion about, are they going to use the 2 midnight rule, or are they going to use interqual in order to determine whether or not a short stay was appropriate as inpatient? Well, it seems like they're looking mostly at one-day stays, so you can understand. I mean, you can expect them to want to look at those. The question became, everybody, because the impression we had was that we're going to start looking at things that were after October 1st, 2015. And that seems to be not true. And as there was, I'm going to show you some articles here in a minute about why that is. So, and then there are some records that were being audited that had been previously audited. That's not supposed to happen. You need to call them to account for that. There are some facilities that are not receiving the record requests at the right addresses, even though they have filled out the address that they wanted it to come to, and they had confirmed receipt of that information from the QIO, and yet those record requests still went through the wrong place. So you're going to have to check with that. You're going to have to watch that. You're going to have to look in the wrong place. You're going to have to inform your people that they may get things from the QIO they're not supposed to get. And it's important because you've got 45 days to respond, or is it 30 days? Shoot, I forget now. I'm confused. But you have a short period of time to respond. Yeah, Dr. Fields saying, it started on 10/1, but there was always a 6-month look-back possible. But that was confusing because of the way they presented it in their webinars. And it confused everybody, but CMS evidently changed their mind, and I'm going to show you an article from a minute from Nina Youngstrom about that. And then there was also the problem that there were some patients who were They were discharged as observation. They were never admitted as inpatient, and they were still they were trying to appeal to the QIO, and that's not legal. They don't have any appeal rights to the QIO if they weren't an inpatient. If they were an outpatient, they have appeal rights to the MAC, not the QIO. But the QIO was seen to be taking up the case, and part of that was possibly that they had gotten the wrong form. So instead of getting an ABN form as an outpatient, they'd gotten a HIM form, an IMM form, which is what you do for inpatients. And okay, here's somebody saying if you tell them a record was already audited, they would just switch out and send you a request for another record. Isn't it better to take a chance and see if maybe they approve it? And if they don't approve it, then tell them it was audited and let them tell you they need another record. Reasonable question. I don't know how good of a strategy that is. I don't know. Maybe that is a reasonable strategy. Because if they approve it, you're down one. Yeah. You're plus one, and you're one in the good column. Well, interesting idea. Okay. I suppose that's a business decision. I don't guess there's anything legally wrong with that. Okay. Shame we don't have Jessica and Abby on. But I would say that you're I guess you could do that. Anyway, seems like that may work. Okay, so here's the answer about why the QIOs seem to not know the rules, is because CMS keeps changing them. In particular, they changed in a document that they posted on November 9th, is that they can apply it for dates of admission within the previous 6 months, starting with October 1. So that was verified. And this is a great article that was written by Nina Youngstrom. If you want a copy of it for free, you can get it by emailing Nina Youngstrom. I put her email on the slide there, and you get a copy of that issue for free because they charge for that. It comes out weekly. Nina does a great job of getting this stuff. She, more than most of the other writers that I see, I think she really tries to understand this stuff, and she does pretty well understand it. And she gets a lot of input from people, and a lot of the people that you'll find even on my show. So anyway, let's see. Somebody's saying the QIO audits, the scope is 0 to 1 day stays. The patient is outpatient on day 1, say November 1, kept overnight, admitted on day 2, discharged on day 3. Is this in scope for the QIO audit? The answer is yes. Yeah, I'm not going to argue with Dr. Hirsch or Stephanie Daniels. I do think that was a 1 day stay because they were only admitted for 1 day. Okay. So, but good question, viewer 105. Okay, so Sharon, I don't know if you had any experience with these things, the QIO stuff yet. But it does seem like. Say again.
I haven't done any of those reviews recently under the new program, Ernie. No.
Okay. Well, and it is in that article. Nina does talk about how inpatient only is showing up again as a problem. Of course, all of this relates to the documentation. It has nothing to do with what you really did. Well, it has little to do with that. It matters because if the documentation doesn't support it, if the documentation doesn't show the need for medical necessity for a hospital stay, period, and if it then doesn't show or support the concept of needing to stay more than 2 midnights, then you won't have a leg to stand on. They will deny that. And with the QIOs, you don't have the problem that you had with RACs, where they're going to go hog wild with it. unless you show up with, what is it, for big hospitals, they're going to do 25, or they're going to review 25 audits every 6 months and 25 records, and for smaller hospitals, they're going to do 10. And I don't recall if they defined that small or large. I mean, they've defined it elsewhere, so we can probably rely on that. And so they're going to do that review, and they will, at least they're going to do a lot better than, more like what the MACs were doing in their Probe and Educate. They look at it, and then they will talk to you about it. QIO apparently is going to talk to you about it a lot more than the MACs ever did. I'm not trashing the MACs here. I'm just saying the QIOs have a slightly different program. So they're going to talk to you more about it. As a matter of fact, if you have a lot of errors in the few that they do, what they consider an excessive amount, well, then they're going to insist that you talk to them. And they will make sure that you get to talk to them and get some so-called education from them. Of course, there's still going to be differences of opinion because the whole thing is subjective anyway. It is not objective as to whether or not somebody is an inpatient or not. So let me see. Yeah, somebody's saying, Dr. Johar is saying that Dr. Richards, who is from, he's from KeyPro, he does seem to be very responsive. Okay. And Stephanie Daniels saying that Dr. Ferdinand Richards from KeyPro, their CMO, he was the one who was pushing for the benefits of a case management protocol so that you could relieve the physicians of that burden, which I think would be a great idea. I do think that's a great idea. I don't know why they would not like it, because that way you can get that out of the hands of, it doesn't need to be in the hands of the physician, I think. It makes sense to me. Doesn't it make sense to you, Sharon? That's more about money than it is about medicine. So it seems to me that ought to be. Go ahead.
There came in where some people felt it was outside of the nurse's scope of practice. I think that's where the pushback came in.
That the notes what?
It was outside of the nurse's scope of practice, what the nurse should be doing in making the clinical designation. I think that's where most of the pushback came from.
Because the case managers were not physicians.
Correct. Yeah. But I do understand it.
Yeah, I kind of hear Stephanie saying, it really has nothing to do with nurses, and Dr. Hirsch saying that the decision to hospitalize is medical, so it's the decision of status is administrative. Although CMS regs now require the doctor to make the decision. Yeah.
Well, usually the reviewers are nurses, and they're using that clinical to help make the designation. So that's where the gray came in, where some folks thought it was inappropriate. But I do totally see where it is a function that can be done outside of that. So, but it just wasn't agreed on by everyone.
Yeah, and I can see the point. But I think if it were my situation, I'd be looking at impressing on the doctors to look. The case managers. Those people are problem solvers. Gee whiz, they're on your side. Use them. Rely on them to help you make that, so that you're not getting queries and you're not getting denials, and you can get the case managers to help you with those decisions. And rely on them. They're the ones who are probably going to stay up on all those regulations more than the physicians in general, I would say.
Well, it would really be easier if they take the recommendations from the public, like the Dr. Meyersons and the Dr. Hirsches, that make these recommendations of how we can do this better and how we can fix this. That would be most logical.
Yeah. Well, of course, it'd be nice if they would listen to the industry, and I don't think they do very well at that, unless they're forced to. And they're, there are people who argue that, well, we just have to keep pushing on them like we did with, filing all those appeals so the Omaha ALJ requests get backlogged. But I don't find that a very effective means of it's sort of like civil disobedience. But I don't find that one to be hugely effective. I think they still take the money, they still sit on it for a long time, and I don't see that changing much in the near future. So I don't know. Okay. So let's switch over to talking about the Medicare Advantage RAC, the new RAC for Medicare Part C. Now, they're really not new. They've been around since the ACA has been approved. They were required, Congress required CMS to create recovery auditors for Part C and for Part D. However, they did not put a timeline in there, so it's been CMS has been slow about it. They're not in a rush, and part of the rush may be that they just they just can't really get a handle on it. But anyway, so CMS published a new proposal back in January. That's what was mentioned in this article. And of course, if they're going to let the RACs have a hand in developing the criteria for this coder guidance, oh my gosh, as if the RACs should know anything about it. What they know about is taking back money. They don't know about coding. I know they hire a lot of coders, and I'm not shaming those coders. I'm just saying that the RACs, they're not run by coders, okay? They're run by people who want to make a profit. So I think this article was right on, saying that by giving the RAC a hand in developing the criteria, they're virtually guaranteeing that there's going to be bounty payments made, on these kinds of claims. So I don't, that's not such a good idea. Then there was this article, which came out a couple days before that other one, and it's just basically pointing out that what this is that they're doing these RADV reviews, and it supposedly looks at a sample of medical records to determine if the diagnoses for risk scores are legitimate and worthy of the higher payments. Now, the interesting thing is that there were some problems created by this, and we'll get to an article about that in a minute, but I thought this was important to remember that they're doing small samples. And the question is that really, statistically, how are they going to use that? Because they're intending to extrapolate, basically. And so that is, to me, it's an automatic grounds for appeal, because you can argue anytime somebody's using a small sample of medical records and extrapolating to any length above that, beyond those records, well, there's grounds, statistically, there are grounds to say it is not appropriate. You have to have a certain number depending on the size of the universe. Go ahead, Sharon.
I agree. They've done that for years. Like, I don't know if any of you guys have had cert reviews, so you could have one or two charts pulled for a cert review and have a problem with one of those records or both and have a 50% error rate or 100% error rate. So they've done that for a long time with cert and even PERMs and some of those other types of audits. They're usually very small samples. And they say that you have this huge error rate from that very small sample. I don't think our provider community, our industry, is ready for Medicare Advantage risk adjustment validation audits. We're not ready because just the concept of, if you're looking at this in the clinic, if you're looking at this on the provider-based clinic side or just in the physician office, those areas aren't really, they don't focus on coding rules the way they should in the outpatient world. In many cases, those accounts are being coded by the physician. They're not being coded by a coder. There are rules and combination codes that are going to impact risk adjustment. And that's what, a huge focus of mine right now is that we've got to pay more attention to our outpatient coding. And a perfect example of that is I'll give you a patient that had maybe a gastric resection, and now he has an ostomy in place. And he goes out and he's at home and he goes back to the doctor's office, and maybe he goes back 3 or 4 months later and his ostomy is still in place. That ostomy is probably never going to get coded on a claim, an ostomy status. However, it impacts that patient's severity. It has a risk adjustment score. It means that that patient's a little sicker than someone without an ostomy. Do you think our physicians are going to know that, to put that on that claim, that that patient has an ostomy? No, they're not. So what happens is you have the Medicare Advantage plan coming back, looking at that chart, seeing that patient has an ostomy, and they're trying to add that code to increase that patient's severity so he can get more, that practice can get more money, and also that plan can get more money for that patient. So this is a very complicated process, and there's so many nuances on it. I'll give you another example. We have a patient that has a primary malignancy and a secondary malignancy. That primary malignancy has previously been excised and removed. He's being treated for that primary right now. That physician isn't really thinking about, I can't code this as a primary anymore, and he's adding that code. But that's an error. It should be a history of a cancer. So that's going to make that claim wrong. So the nuances of risk adjustment and coding is complex. And I just really don't think we're ready for that. That sometimes impacts the error rates that's happening to these Medicare Advantage plans. In some cases, are they using coders that really don't understand the rules to add these codes to bump up those numbers inappropriately? There are just many nuances here, and I don't think we're ready for it. But the ultimate goal is really to ensure we have enough money for that plan so it can trickle down to the provider. And I'll give you another perfect example of that. My mother-in-law, she lived with me for a long time. She's deceased now. But she was a very non-compliant patient, loved her to death. She had a multitude of medical problems. She had CHF. She had diabetes. She had end-stage renal disease. And when you think about her, if her claim was never coded appropriately that related all these diagnoses, that said she had a hypertensive heart disease with that it impacted her renal function, that she had a diabetes with renal manifestations, the severity of her record was going to be inappropriate because many times that physician would just say she has unspecified diabetes. She has hypertension. He never said that she has hypertensive heart disease with renal failure or stage 3 renal disease. That never got coded on her chart. So therefore, the plan wasn't able to receive more money for her, and it wasn't able to trickle down to the provider. So Medicare Advantage is something that's very complex. I'm really afraid of the RAC getting a hold of that because it could take away something that could rightfully be yours. Hopefully they understand the rules better, but as we can see from inpatient coding, they don't. And this is different. We need to look at our ambulatory documentation and get a handle on that because we're moving into a territory where risk adjustment is dictating how we're going to get paid. It's going to be a part of our new MIPS program with that Medicare incentive payment system that they're going to start on the physician side. It's embedded within there. We have got to really get a hold of risk adjustment, not only on the inpatient side, but also within the clinic. And I'm going to start talking, Ernie. I could talk all day about it.
Okay, well, here's Stephanie with a question in there. Before that, viewer 88, I was pretty much saying This is probably why we're seeing an uptick in DRG reviews by the Medicare Advantage and commercial carriers. They're attempting to correct their errors with the RADV to show the commercial won't get dinged, but the providers are again in a loss column because we have to send back the difference between the old and the new DRG. Yeah, I don't know if they, yeah.
Could be, and that's another interesting point. Let's talk about DRGs for a second, because when we think about a CDI program, the Clinical Documentation Improvement, they're trying to improve documentation. They're trying to show severity by getting MCCs and CCs. That's what risk adjustment is. It's improving documentation by showing severity. And when we're calculating that DRG on the inpatient side, some of those risk adjusters aren't MCCs and CCs. They are regular diagnoses that if a coder doesn't know them, and your grouper is not going to calculate them. So they have to be resequenced. So it brings a totally new caveat to the reimbursement process.
Yeah, but to me, it's a big question as to what actually trickles down to the provider, if ever. If it's wrong, I can see the payer going back to the provider and wanting the money back. If they improve it, I don't know that they do that. And then there's the question of, which we're going to get to in a minute, about the kind of documentation that's going on by the Medicare Advantage provider rather than the original physician. But here's something where Stephanie was asking, it's my understanding that the RADV was intended to double-check the Medicare Advantage insurer to make sure that their claims for risk adjustment dollars was legitimate. And it really wasn't meant to check the hospital claim. Does anyone know about this? So what do you think, Sharon? I mean, I don't. That's my question.
Let's talk about a Medicare Advantage for a second. So it's all about the member, right? So wherever that member goes, whether it's to the clinic, whether it's in the hospital, whether it's to get their drugs from pharmacy, all that impacts their risk adjustment score. So any one of those visits can have that impact. And you are right, Stephanie. That's what risk adjustment validation is to validate those codes from all those multitudes of visits to ensure that they were documented and recorded in the record and clinically justified. So that's the purpose of it. The problem there will be, of course, who the reviewer is and their understanding of that information and how it translates, just like it is now with the DRG denials that we get for clinical validation, where they say, oh, your acute renal failure is not clinically supported, when I can see very clearly it is. So that's an area that I fear for us to move into.
Okay, yeah, and that's the question I got. Mary Harless was saying they deny the admissions that were pre-approved, but their reimbursement from CMS is not revised. So the provider loses money, and the Medicare Advantage payer loses nothing. That's the part I think that is the big disconnect.
Well, and it goes on to something else. Okay, so let's say our RACs are going to do the risk adjustment validation. Are they going to be looking at my member's prior year to justify that money from the prior year? Are they going to impact my current year and impact the money I'm going to receive next year? So there are some ins and outs to that can have some financial impact for a hospital for the future. You know, because remember, what happens this year is calculated, analyzed, and they tell me what my reimbursement will be next year based on this year. So I would suggest that, we all look at risk adjustment a little more closely, that we work with our physicians, certainly that we own, that we can have impact on, work with them on their documentation, work with them on their coding. But, the problem is that other email, Ernie, I sent out earlier in the week where it talks about we've lost our physicians, in some of these processes because they're using the EHR and they're just assigning the codes, and the code is just going out of the door. And there are rules behind coding. And that's where the problem lies, that we can't show severity accurately because in the clinic we're not using the rules properly.
Well, and it brings up this issue about, well, what is the documentation that they're using to do the risk adjustment? And this was an article that Dr. Hirsch had published on RAC Monitor, back in November. That was in 2014, Dr. Hirsch. Anyway, so this has been around for a while, obviously, but it was from the OIG work plan for 2015, and what was happening was the Medicare Advantage plans were using separate contractors to hire physicians to go to beneficiaries' home and conduct an H&P exam, and then they submit those to the MA for the hierarchical coding, and that would maximize their monthly payment. Now the question is that appropriate? They're not providing any care.
We have chronic condition management now, Ernie. Chronic condition management allows payment. Chronic condition management includes where you can go to a patient's home and get information about their chronic condition. The problem in all of this isn't necessarily that we're doing that. The problem is we're not capturing everything we need to capture in the actual clinic. Our physician doesn't know that there is a diabetes combination code with renal function. I mean, now he probably does with 10, hopefully. But, that's where some of the disconnect is. That's why they were having to do that, because we weren't showing it properly within the clinic.
Well, now, Dr. Hirsch, are they still doing this kind of thing? Or is this, because this is like they're still doing it? Okay.
They're doing it more. There's chronic condition management now, and you can go out to your patient and have a face-to-face home visit. Yeah.
But that's it's like getting, to me it was like, okay, there's going to be a second opinion. It reminded me of this Henny Youngman joke, so I had to stick it in here. And I'm dating myself knowing Henny Youngman, but doctor examines the man, tells me he has 6 months to live. The man says, I want a second opinion. Doctor says, okay, you're ugly too.
Yeah. And it's a part of it could be a part of the annual physical exam. You can go out and see your patient at home for a physical.
Yeah. Now there was somebody asking about what do you do with are you foregoing contracting with Humana? That's a very interesting question. Well, now, Stephanie and Dr. Hirsch, are you talking about reading your book? Do you guys talk about this in the book? Yeah, the book.
Oh, yeah.
Put the link in there to your book in the chat box.
Yeah.
And I do recommend to people that it's a good book written by Stephanie and Dr. Hirsch about it's largely about doing case management and that kind of stuff, right?
Yeah, we talk about that, about being a part of that contract negotiation process, understanding your contracts. That's very crucial because many, those conversations are had outside of, the HIM and coding department and outside of your physician advisor, outside of your case management, but they need to be really involved in those conversations.
Yeah. And then there's also some good information. I'm going to have Chris Baggett back on the show soon, and we're going to talk about this, some of this stuff. He's had some letters. He's had some success with Aetna and Humana fighting them. Now, it wasn't his local. It was on the West Coast, and it was, with specific contracts. But at least he had a template for letters that talk about this and give you a way to talk to the insurer about it and to fight them, because you got to know the contract, and you've got to have appropriate stuff in your contract to be able to fight them, but you may not even know that you can do that. So it's worth looking at. And Chris has some sample letters on his site. We'll have him on the show again to talk about it. Okay, and there's the link to the book by Dr. Hirsch and Stephanie Daniels. Again, I encourage stuff like this. You got something that's good to read, we want to know about it, and we'll present it to people. Okay, so let me see. What did I miss in the chat room? Yeah, Stephanie's saying every provision in a commercial contract, including your Medicare Advantage contract, is open for negotiation. If you're silent about their policies and procedures, then you got nobody to blame, basically, except yourself, your hospital's contract administration. You got to be in touch with them, and you got to know. And I think the contract administration is not necessarily going to know what kind of problems you're having unless you tell them. So get with them and talk to them about it. Say again?
And something I will add, Ernie, I know many times we have, let's just say you did agree that you're going to be a part of a Humana plan for Medicare Advantage patients, and they contact you, the provider, about coming to speak to your physicians about risk adjustment and details of the plan. I know lots of providers shy away from that. That, as far as I know, is something that is allowable that can help our physicians understand a little bit about documentation and the requirements of that for the plan or for patients in general. So that's definitely a conversation to have internally and to, make those decisions about whether you're going to have that done or not, because how our diagnoses are reflected today, this year, are going to impact us financially in the future because of all the quality changes that are about to happen. So you got to think of the outpatient side as well as the inpatient.
Yeah, I heard somebody asking on a totally different topic, and I'll just read it in so people can, so it's in the show. But on an unrelated topic, has anyone seen a significant change in their RAC ADR limits? Ours are only a third of what they were. Well, I would have expected them to be a quarter because I thought they'd cut down the RAC ADRs to a quarter of what they were before. So, interesting. Of course, it may be that they expanded your limit before they started sending you new reviews. Yeah, somebody else, they went from 243 to about 50. Okay. Well, see, that's about a quarter. Right, it depends on your denial rate, but I haven't seen that formula in a while, so I'm not sure what that was. Maybe we'll try and dig that up for next week's show. Anyway, listen, I got a few more slides to go through before we're done. I'm trying to keep this to an hour. This is the CMS page on your screen that shows who the Part D RAC is, ACLR Strategic Business Solutions. So apparently they're not I don't recognize them as being in healthcare, so what a surprise. But anyway, the interesting part to me was not so much who that contractor was, but that the audits that have been done for CMS have never been made public. But the results from them have been publicized, and it's showing that it's costing CMS millions more. And there are huge billing mistakes being made by the Medicare Advantage plans. Billing mistakes being, they're overcharging. And of course, now this is an article from back in July of 2015. There's a link for that so you can go read it. Here's another article on June 4th. I like this one more. This is a very interesting read. The Medicare officials who run the program will not, don't want to be interviewed by even somebody like the Center for Public Integrity, and look at the results. These are the findings that CPI found when they looked at the results that they got. They couldn't find out who. CMS wouldn't disclose who was making the errors, which I find disingenuous. But they say they can't. So I think CPI is suing them to try and get that done. But it says that the risk score errors triggered $70 billion in improper payments from 2008 to 2013. They're suing to make these records public. And they're saying that basically the risk scores rose sharply In 1,000 counties, that's a third of the counties in the U.S., boosting taxpayer costs by more than $36 billion, over the estimates of what it should have been if you were just in standard Medicare. Well, wasn't Medicare Advantage supposed to lower the costs? It's increasing it. It's saying that they're 25% higher in general across, and that's just counting those 5 states that they list there. So, yeah, somebody's saying so. Yeah, big surprise. No, it's not a big surprise, but this is the proof of it, and CMS is holding tight to some of this. So fortunately, CPI has taken them on to do that. And there was a very interesting graph in that article that the first article I showed you. It was not the last one. This one. In this article, there is a graph. This graph is from CMS. And it's interactive. So if you go to the article, you can do this. What you do is you click on one of these dots, and you get some text that shows up and talks about that particular plan. What these lines are is that in 2007, none of the plans had any members, so they show up as 0. And then, this particular plan in 2008, it showed up as, this is the kind of a growth it had. I think that was in the risk score. And so, see, this one I clicked on this one here in 2011. This more than a 52% change since 2007. That was one of the Humana plans. Matter of fact, a lot of these on the top of the graph are Humana, as a matter of fact.
Yeah,
and they went. Yeah, they've grown that risk score tremendously. And that kind of makes sense because of what we've seen that they were doing. They go out and produce their own documentation.
It's such a catch-22 situation, Ernie. The plans, they get more money for these patients, and they go in and dig through and try to find that documentation. But if you're contracted with that plan, it trickles down to the provider.
Yeah.
And that's what people miss. Instead of getting $2,000 for my mother-in-law to last her that entire year, if she would have been reported appropriately, they could have gotten $8,000 for my mother-in-law to take care of her care the entire year. So it's a catch-22 situation. Kind
of strange. Anyway, that's all we have time for. I just wanted to show you this graph. You can go look at it. And coming up on, like I mentioned, we're going to be talking a lot more about outpatient. I know Sharon wants to talk about, looking at outpatient, as she said, and making sure that the coding is being done properly, because there's a problem with all the EHR, with the, no electronic medical records, and physicians doing it on their own, and they don't really understand. So how can we do that? There's also the question of, like I said at the beginning of the show, are we fighting the trend? Are we fighting City Hall? Are we putting on Superman's cape when we keep trying to do inpatient? They obviously want us to do outpatient a lot more. Why not do that so we can get paid? Hopefully we can get paid more. Maybe those things will change. Who knows? And then there's 3 shows that I'm working on, like something that we're going to talk about, tools that will help you predict denials. Those should be helpful. We're still trying to put together a show that talks about how do you show ROA for physician advisors and rounding programs. And then Dr. Jelen Zellum has said that he'd come on the show again, and I don't care what he talks about. We always have a good show when he's on. And so we're working on that to get him in. So that's all the time we have time for today. I do want to thank everybody for being with us. We will be back live on Friday, January 22nd. So watch for my announcements. Thanks to everybody for participating. Great conversation in the chat box today. Of course, thanks to Sharon for helping me out today, and I wish Bill could have been here. Hopefully he'll be back next week. And, of course, I want to thank all my sponsors, Health Law Partners, MedLinks Cost Containment, Aerolib Healthcare Solutions, and Recovery Analytics. It's their contributions that make these broadcasts possible, so you have to pay attention to them. Go visit their site. Take a look what they got there. So watch for my emails about next week. Last thing I've got to share with you is remember, when you're sending out a claim, you really want a big yes. You do not want a maybe. So you don't want the 8-ball to say, reply hazy, try again later. You want it to say, yes, this will go through and be paid. So anyway, thanks very much, everyone. We'll see you next time when it's finally Friday. Have a great weekend. Bye-bye.